Hello and welcome to another episode of the show Medical Talk at Dasman Diabetes Institute. I'm Dr. Mohammed Al-Mahtab. Today, we will delve into the latest advancement in healthcare and medical research. In this episode, we will focus on the remarkable efforts of Dasman Diabetes Institute in Kuwait. Dedicated to improving the lives of diabetic patients, Dasman Diabetes Institute excels in providing cutting-edge research, comprehensive care, and initiative treatments. Their holistic approach not only addresses the medical needs of individuals with diabetes, but also emphasizes preventive measures to combat vascular diseases and other complications associated with diabetes. Join us with Dr. Aziz Al-Muzaini, Vascular Lab Consultant at Dasman Diabetes Institute, as we explore the impactful initiatives and services offered by this esteemed institution and learn valuable insights on managing and preventing diabetes-related health issues right after this short break. Welcome back. We're happy to have with us in the studio Dr. Aziz Al-Muzaini, a vascular lab consultant at the Dasman Diabetes Institute. Dr. Aziz, welcome to Medical Talk.
Thank you, Dr. Mohammed, and I would like to thank all the staff and the invitation from the Medical Talk.
Pleasure. It's always a pleasure to have you. We have so much to talk about, but let's start with, if you could give us a brief about the services that the Diagnostic Imaging Department Center here at Dasman offer.
Yeah, so in Dasman Institute, we have one of the most advanced diagnostic imaging center, DIC, which has a lot of modalities for diagnosis, including all advanced radiological machines, if you say MRIs, CT scans, ultrasounds, and we have also the vascular lab, which we have the Doppler machines and the duplex machines to diagnose all vascular diseases. Okay. So it's to say that the Dasman Diabetic Institute, one of the institute for research, and I'm proud to say that it's not only in Kuwait, it's famous in the Middle East and even worldwide when we go to diabetes and the research about diabetic patients.
I like what you mentioned, that there is a research component to the institution as well, plus the treatment, sector that you are offering.
Right.
Now, in a nutshell, can we safely say that a diabetic patient can find all the necessary diagnostic testing or images that they might need in this center?
Of course. From A to Z.
So they don't have to go back to their hospital or to another location to get a...
If patient come here to Dasman Institute, he can have all the services from A to Z.
Exactly.
Because we have OPDs for blood sugar control.
Yes.
We have ophthalmo for the eye complications. We have nephrologists. We have even the dentist for the diabetic patients, so they can have all the services from A to Z.
Exactly. Yeah. I'm happy that you mentioned that it's covered the whole spectrum of medicine that the patient can experience, from even ophthalmology up to the foot.
Yes.
Basically. Which leads me to my next question, because you are one of the best and well-known doctors in that field. I want to ask you about the definition of a diabetic foot.
Yeah, diabetic foot. Okay, so let's start with diabetes. Diabetes can cause 3 major complications. It can affect the eyes, kidneys, leg and foot. And the foot is the most important. Why? Because unfortunately, we don't have such screening program to discover the disease early to protect amputations. Okay, so let's say, back to your question, the definition of diabetic foot, it's an ulcer or a gangrene or a wound in the foot due to three things: either infection, peripheral neuropathy, which is nerve damage, okay, or peripheral arterial disease.
Okay, so basically the blood flow to the region is compromised.
That's right.
Exactly. So, Dr. Abdul Aziz, is it common?
Common, yeah, it's so common. When we talk about diabetes, Kuwait is the second country worldwide who have number of diabetic patients. So we are number 2 worldwide. Diabetes itself, last year they said there is about 400 million people worldwide which have diabetes. And when we go back to Kuwait, 25% of Kuwaitis are diabetic. Let's say 1 out of 4 or 5 persons will have diabetes. So the disease is very common. This is when we talk about diabetes per se. But when we talk about diabetic foot, we said that one of the major causes is the peripheral arterial disease.
Yeah.
And what is the causes of peripheral arterial diseases? The causes are so common. Okay, so when we say the causes of peripheral arterial disease, diabetes, number 1, hypertension, high cholesterol, obesity, lack of exercise, smoking, people who sit with smokers, family history of cardiovascular diseases, necessary anxiety, stress. All these can cause peripheral arterial disease. So, and all these factors are, as you know, it's so common in our country.
Exactly, and sometimes it happens all together in one patient. Patient who happen to be an obese, smoker with high blood pressure.
Most of them.
And could be also a diabetic.
That's right. Yeah. That's right, Dr. Mohammed. Yeah. Rarely we see that patients has only one of this list. At least 3 and above: diabetic, hypertensive, smoker, obese, lack of exercise, high cholesterol. Even they have more than one risk factors. That's why the disease itself, as a peripheral arterial disease and diabetic foot, it's so common in our region.
And it's quite challenging. But in terms of statistics, who is more prone to it? Is it males or females?
When we talk about peripheral arterial disease, males are more common, okay, till the age of menopause.
Exactly.
After menopause, it will become equal.
Yeah. After the estrogen, basically, depletion, then we will see it more in females.
We'll not see it equal. We'll not see, I mean,
But in your clinic, you
no,
see
most of it males. Really,
males.
To be honest, most of the I see patients with peripheral arterial disease, they are males.
Do they come to you late? Unfortunately,
this is a very nice question. This is the aim. I mean, for this interview, I want to increase the awareness. Yes, they come late, Dr. Mohammed, especially diabetic patients. Okay, before coming late, let's say, what are the symptoms? Why do they come to me if they have peripheral arterial disease? If they have peripheral arterial disease, they can be asymptomatic without any symptom. The most common symptom is intermittent claudication, which is the definition of it: muscular cramp. It could be the calf muscle, thigh muscle, according to the stenosis, that comes with effort and relieved by rest. Okay, this is the most common, but it's not necessarily it will be happening in all patients with peripheral disease. Then, with more narrowing, patient will come with rest pain. The definition of rest pain: severe burning pain in the foot and toes, not in the calf and thigh, foot and toes, that wakes the patient from sleep, and he will hang his leg down. He needs any gravity, so he can increase the perfusion. Or they can come with the complication, which is the ulcer or the gangrene. Believe it or not, we see patients who come to our office with an ulcer or a gangrene.
How long this been going on?
So this is I mean, one of the messages that, especially in diabetic patients, we don't depend on symptoms. They can be asymptomatic. They can have a severe disease without symptom. Why? Because they can have loss of protective sensation. The nerve damage can lose their protective sensation. What is the protective sensation? I mean, they cannot feel the pain or the injury or the trauma. People who come from camping, sitting near a fireplace, or the charcoal, they put their feet, they can have a burn. He will not feel it.
Exactly.
His friends will see his foot. People with a screw or a pin for 3 days in his leg, his wife will see it. So this is loss of protective sensation. We don't depend on pain. So that's why we see them early in our clinic. Maybe they are asymptomatic, they have a mild disease, didn't show the symptom. And most of the diabetic patients, they will not feel the pain, so they will not come to you. So this is one of the advices to increase the awareness. Come and check yourself, even if you are asymptomatic, especially if you are diabetic.
Okay. We got more to talk about, but we have to take a short break. We'll be right back. Stay with us. Okay. Welcome back. We're still talking in the studio to Dr. Abdul Aziz Al-Muzaini. Dr. Abdul Aziz, before the break, we were talking about the diabetic foot.
Yes.
I want to ask you how severe or serious it is, basically, because a lot of people, they may underestimate the severity of the situation, basically.
You are right, Dr. Mohammed. Lots of people, they underestimate. I'll give you an example. If people hear about cancer, so they will get shocked or afraid, you know. The 5 years mortality or the death rate from diabetic foot ulcer, peripheral arterial disease, okay, critical limb ischemia, much more than most common cancers, let's say breast cancer or prostatic cancer. The death rate from these diseases are much more.
Yes.
So when you hear about peripheral arterial disease and you hear about diabetic foot, really, people are underestimating. But the 5-year mortality, if you don't treat it, it's much more than the WHO.
Yes.
The thrombo or arterial thrombotic diseases are the #1 causes of death worldwide.
Yes.
It's more than cancer and AIDS combined.
Wow.
Imagine. So it is a common disease. When we talk about diabetic foot, you know that there is more than 1 million person diabetics, they will have limb loss or amputation each year.
Wow.
So if you calculate this, every 20 to 30 seconds, there is amputation worldwide happening.
That's a significant number.
So it's a significant number. And 80% of these amputations are preceded by foot ulcer. And the good news, now we said the bad news is the number is so bad and scary. But the good news, 80% of these amputations and ulcers can be prevented.
But if they come on the right time.
In the right time.
Okay, so
It's about timing.
It is all about time. So walk me through the time frame in terms of, like, if patients comes to you, whether they're symptomatic or asymptomatic, what should they expect in terms of starting from the initial examination until the diagnosing, until coming up with a final treatment plan?
Excellent. So when the patient walks into the clinic, we'll take a detailed history about the risk factor that we said, about the diabetes. Is it type 1 or type 2? His medications for the diabetes. If he have any other risk factors, hypertension, the cholesterol, we'll take his weight and BMI. So we can know all his risk factors for the peripheral arterial disease. Then we'll ask him about his symptoms. If we have an intermittent claudication, like we said, if he have a rest pain, if he have other symptoms, it's not necessarily related to the arterial, it could be to the peripheral neuropathy. Does he have numbness in his leg, tingling sensations, coldness of the leg, hotness of the leg? Some people, they will have an alternating sensation. Sometimes it's so cold and sometimes it's so hot. If they have electric-like sensations, if they have pin and needles, all these questions. If they have past history of foot ulcer or a wound, if they have a family history of arterial diseases, diabetes, all these things. Then, if we finish from the history, we will do an examination, clinical examination. We will see the foot, we'll take the pulses, then we will see if there is any, by inspection, if there are any changes, if there is any redness, any swelling, even we see between the toes if there is any fungal infection, fungal toenails, skin changes, all these things, and we record all the findings. Then we'll start screening the patient. Okay, let's say the patient is asymptomatic, he's diabetic, hypertensive, asymptomatic, he have some tingling or even zero symptoms. So we'll start with the most important test or examination, which is called the arterial Doppler.
Arterial Doppler.
This arterial Doppler is a machine that we measure the brachial pressure, always systolic pressure, not the diastolic, systolic pressure, and we put the blood cuffs also in the legs, above the ankle, and we have a Doppler, which is an ultrasound, so it will record the waves and it will give us a number. So why this test is important? This test, it will take 10 to 15 minutes maximum, and it will answer two important questions for me. Does this patient has peripheral arterial disease or not? This is the most important question.
Okay.
And if this patient has an arterial occlusive disease or stenotic disease, it will give me a hint about how severe is the disease and about the location of the disease. I'll give you an example. So this, and we can see also the blood flow for each digital artery in the foot.
Oh, wow.
So we can
Specifically, yeah.
from the large artery coming outside the heart till the smallest artery in the toes.
So you know where the exact blockage?
Yeah, not exact, but about. Because it's still called physiological test.
Okay.
It's about cuff and waves. I'll give you an example. And the good thing is it will give you a number. This is why all doctors love this Doppler.
Figure.
It's a figure. The normal number is 1.2. So let's say 1.
Okay.
Anything below 1, 0.8, 0.7, 0.6, there is a disease.
There's a problem.
There's a problem. If it's 1, there is no problem.
Okay.
Sometimes we have it above 1. I mean 1.5, 1.7. They might have calcifications, but I will not go into these details. But why? According to this number, if the number is 1, patient is normal, no arterial disease. Patient 0.7, 0.8, they will have the intermittent claudication. When they reach 0.3, no, it is severe disease. They might have a rest pain, gangrene, it's 0. So according to this number, we know that if there is a disease or not is the most important, because a lot of symptoms, they mimic or they look like the arterial disease. A lot of patients, they have L4, L5, you know, they have peripheral neuropathy, they have some cramps. So how to differentiate it? By this test, which is fast and accurate, and will tell me the patient is, if patient normal, so we'll refer him to the neurologist, you have a nerve problem. If the patient is an arterial disease, we'll deal with the arterial disease. So this is the first thing, which is the arterial Doppler. Let's say by arterial Doppler, we found that the patient in the thigh, he have a significant disease by number, let's say 0.5. And the wave shows that he has stenosis in the thigh, but we cannot know where exactly is the disease. Now we can take him to the other machine, which is called the duplex. Now the first machine is Doppler. The second machine is duplex ultrasound. Duplex ultrasound, we can see in the screen with colors. We can do what we call arterial mapping from the abdominal aorta till the small arteries. And we'll know here exactly where is the stenosis.
Okay.
Here we can know
exactly. More specific. Basically.
More specific.
Yeah.
But we do it in patients who are selected, patients who will go for treatment, I mean interventional treatment, either by angio or by surgery bypass. So we do it, but let's say patient 0.8, 0.7, all the intermittent complication, no need for intervention, we not do it. We'll keep it just before planning for intervention, we will do this mapping.
Exactly.
So let's say now patient normal, we'll go back to the question. So medical history, clinical examination, then Doppler ultrasound, it's a must for all.
It's a baseline.
Baseline. Then we will go and see the protective sensation. We have something called the monofilament test. Patient will close his eyes and will bring like a feather, okay? And we will touch tip of the toes. If he feels them, his protective sensation is excellent and intact. We have something called also by vibration. This is all for the protective nerve. Then we have something called the pseudoscan machine that we measure the autonomic neuropathy. How dry is the patient, and how it will give me if the patient legs is so dry, we can see it, and we can detect it by this machine also. Because when we'll talk at the end about the advices, the moisturizing is very, very important for this patient. So after we finish arterial Doppler, clinical examination, duplex, we said selective. So not for every patient. The monofilament protective sensation, we will sit with the patient. We'll tell him that you are in the green zone.
Okay.
If
so you start classifying and giving the diagnosis.
And this is worldwide classification, and I'm proud that I did the research with my colleague Neil Baker, he's a podiatrist, and our paper was published about this screening protocol or algorithm. So patient, if they have normal arteries and normal nerves, they are in the green zone. If one of them is affected, either the nerves or the arteries, they will be in the orange zone. If both of them are affected, they will be in the red zone. If they come with an ulcer or a gangrene or a wound, they are already in the red zone.
Automatically by the